So the next talk is actually my talk, and we're going to be talking for the next 15 minutes on expandable technologies. These are my disclosures. So it's interesting, if you start looking back in the literature, some of the pioneering spine surgeons thought that this was a good idea even 15 or 20 years ago. So some of the earlier patents on expandable technologies in general were in the mid and late 1990s. But it's interesting, there was this big gap of time where the companies really didn't see necessarily the role in these products, and nor did surgeons. And so this is one from Sophomore Danek. So Sophomore Danek, for those of you that don't know, it used to be two companies, one out of France and the other one out of Memphis, and then they merged, developed Sophomore Danek, and subsequently was bought by Medtronic. But with that said, this was a patent that was issued in, it's an international patent that was issued in 1998. So going back to kind of some of the basics of this, the way I like to simplify things into, okay, we have expandable technologies. There's generally two categories. There's the vertical expansion technologies, which the earliest ones were essentially just shims or wedges. There's the expanding cylinder type of technologies. And then the most common on the market today are the jack type of mechanisms. But then there's also the expandable technologies as well, and we're going to talk a little bit about all those. So, and also now in the market, if you look at any of the major spine groups, they now have almost a full product line of posteriorly based products, which were the first to the market. Those were the PLIF and TLIF cages. Now there's the lateral, whether it's anterior to the psoas or trans-psoas, that are expandable. And now there's also ALIF products and oblique products that are expandable technologies. So just to go kind of through, and I'm going to try to make this as industry non-biased as possible by not saying who the manufacturers are. But you can see this is the kind of classic PLIF bullet design. This is made out of a titanium product, and you can see that it expands to a certain height. This product itself and other products can also expand differentially, so you can have greater anterior expansion than posterior expansion, as I'll show in a minute. As Sig knows the one on the right very well. But on the one on the left, these are now expandable TLIF technologies, which are gaining traction in the market as well. And then you have the lateral designs, and these are non-lordotic lateral designs. And you can see on the left-hand side that is made out of a PEEK hybrid construct, and then on the right-hand side a titanium construct as well. And then these are now the newer lordotic mechanisms that can be placed via a lateral approach as well. So you can see as you engage the end plates, you can lordose the spine via a lateral approach as well. And the argument with these are you can place a smaller implant in and then lordose it to the degree that you would like. And then finally, these are the ALIF designs. We can talk about the pros and cons of these, but this is a titanium product that you can see not only does it expand, but it can be treated as a standalone device with screw fixation internally. So to get back to some of the basics with this, vertical expansion, again, can be done circumferentially in the spine. The advantages certainly are there is disc height restoration with all of these products, anteriorly and posteriorly, lordosis restoration, and it actually does lock the implant pretty well from those that I have used for immediate stability, and that helps prevent migration. The disadvantages, of course, are with the ability to expand these implants, you can get subsidence, especially if you don't place them peripherally along the apophyseal ring. And a lot of the early devices, particularly the bullet PEEK devices and PLIF devices, those were on no apophyseal ring at all. So a lot of the products limited the amount of expansion that you could do to try to avoid subsidence. Also, a lot of these have underestimated the actual lumbar lordosis that is created. So it's very important for all of us to know, and I think we all do, that just because you're placing an implant, expandable or not, that's 15-degree lordotic implant or a 20-degree or some of these hyperlordotic implants, that doesn't mean at the completion of surgery that's how many degrees of lordosis that you get. One of the big difficulties with these implants is that almost all of them are very difficult to post-pack. So you pack a little bit of bone in this very small surface area internally of the implant, then you expand the implant, and it's very difficult to actually place bone within the implant. So surgeons that are more meticulous place bone around, but a lot of these expanding technologies make it very difficult to post-pack bone, whether in the implant or around the remainder of the disc. So these are the other designs that are on the market currently, and these are the horizontal expansion mechanisms. And you can see a little bit different. The one on the left is made out of a titanium product, and you see it goes in like a bullet and then can expand outward. And then on the right-hand side, you have one that kind of looks more like a snake, or it kind of looks like a slug to me. But with that said, the advantage of these is that at least when you place them interbody, they have a very small footprint, and they expand in vivo to enlarge their footprint. They also tend to be a little bit easier to be able to post-pack within the confines of the implant, because again, it's a much larger footprint, so you can place bone internally to it. The disadvantages, though, is it's really difficult to control lordosis. So these are non-lordotic devices in general. And also, when I've tried them, you have to a little bit undersize them so you can expand them. So if you really jam them in, you can't expand them, and then you have a non-expanding implant that really does nothing for you other than blocks your annulotomy window to place bone. So typically when I've used these, instead of placing a 12 or 13 millimeter implant that I would with these vertical expanding technologies, I typically will place a smaller one like a 10 or 11. So I'm not totally sold on that product, but some people do swear by it. So this is a case report. This is a 60-year-old female, low back pain, left lower extremity radiculopathy, fairly classic L3 distribution. She feels like she's leaning progressively to the left-hand side. You can see high ODI and VAS. You can see that she has this left-hand side mid-lumbar deformity, and you can see a little bit more clearly. But the lumbosacral spine actually looks very good. So, and she's also in good sagittal balance. You can see her MRI. She's got quite advanced spondylosis at L2-3 and L3-4. L4-5 actually looks quite good, and so does L5-S1. Whenever I do any kind of deformity work, I always get CT scans because as an orthopedist, I love seeing the bony architecture and what happens over time with these deformities. You can also see on the coronal image, if you're thinking about correcting her coronal plane imbalance, you may at least consider putting one wedge device on the right-hand side at L3-4, and then at least consider at L2-3 to put a wedge device to address their foraminal stenosis. And this is exactly what I did through a MIS procedure. So this is an expandable hybrid cage. You can see it's made out of a PEEK and a titanium product. And we got good height restoration and correction of the coronal deformity as well. And this is her post-operatively. Now, one of the issues is that these expandable products are expensive. They're expensive to make, so the manufacturer spends a lot more with these products, and also the payers. So as you can see, the manufacturer in some cases spend 10 to 20 times more than on a PLIF or TLIF titanium cage, for instance. And certainly they're much more expensive for the hospitals to purchase. And the real question is it really worth the additional cost both to the manufacturer and payer? And I think time will play that out. So the cons of expandable implants, and these are some of the more recent papers that have been published in the last couple of years. When I did a PubMed search about a week or two ago, there was 20 peer-reviewed papers on this topic. And you can see this is a retrospective series of 25 patients with a PLIF standalone Verilift implant. And you can see in this single surgeon outcome measures that he felt that at least 71% of his patients had done quite well without revision surgeries. And again, this is a standalone device. It's FDA approved for standalone. Fusion, and he only saw half his patients back at 1 year. You can see out of 25, he only saw 12 back, but at least those that he saw back seemed to heal pretty well. At least in his conclusion, you can see that for a 1 or 2 level standalone PLIF, this is a viable technique. Another surgeon looked at this. Actually, this is a pretty interesting case, and I think all of us in the room may sometimes feel the same way when we do discectomies on patients. Some patients you just know, particularly if they have big central disc herniations with a lot of spondylosis of that segment, do they really do well? So this again is a retrospective study looking at 40 patients treated with simple discectomy, 20 patients treated with expandable cages without implants. And what they essentially found, if you look at the results on number 2, significant decrease in VAS scores seen in group 2 compared to group 1. So what they're saying is they did a little bit more surgery, but these patients tended to do better, at least in their registry and the way they reviewed these. And about 80% of their patients fused based on CT imaging. Next, the Spine Journal, you can see this is another pro for interbody implants to begin with, but this is a study of over 1,000 patients. They looked at how many retropulsion cases that they have that came out back through the foramen, and they found that out of their 9 cases, the majority were at L5S1, and their conclusion was because of the anatomy differences at L5S1 with that fish mouth segment at L5S1, typically an expandable cage may be superior at that level to avoid in retropulsion of the implants. We're just going to go through this for time's sake, but this is another actually interesting case looking at 61 patients, looking at banana-shaped or straight implants, and you can see that at least in the banana group where they placed the implant anteriorly along the apophyseal ring, they feel that that was a better way to restore not only the disc height, but the lordosis of those segments. Expandable cons, other than the cost, risk of overexpansion. One of the issues, particularly if you use some of the biologics, BMPs, is if you get expansion into the actual apophyseal ring or the vertebral body itself, you can get a substantial amount of reaction. I think any of us that have used the bone morphogenic proteins know that early in our career when we were doing a higher dose and quantity of the product, you had a lot of reaction, including sclerosis, in-plate edema if you did MRIs post-surgically, as well as sclerosis, and in many cases the MRIs almost look like an acute infection with those. So be careful if you're using the expandables and using the biologics, particularly the BMP2s. Particularly with the ALIF, in very collapsed L5S1, if they've previously had decompressions, be very careful not to over distract on isthmic spondies, because then you can get L5 radiculopathies. And then if you do coronal plane imbalance procedures like the case I showed, I intentionally improve coronal imbalance, but you can also create coronal imbalance if you use unilateral implants with wide decompressions and facetectomies. So before I finish, I just want to show you at our center, which is in Minneapolis. You can see on the left-hand side, this is a non-expandable cage. So it costs $2,500, and an expandable cage is twice as much. And then if you start going into polyaxial screws, our screws are $575 per screw, but if you use cannulated pedicle screws, it goes up to nearly $1,000. So if you use this new technology, including expandable cages and perc screws, whether you do it with fluoroscopy or O-arm stealth or Mazor, the cost difference is about $4,600 per level using this newer technology. So the hospitals don't really like it, of course. And just again, because we're almost out of time, and again, if anyone wants to read the other articles, they are certainly in the course handout that we're going to give at the end. At least my perspective in summary, our expandable implants are here to stay. Expandable implants absolutely have their role treating spinal deformity, and both in the sagittal and coronal plane. but surgeons, we all should be responsible and at least look at the added cost of these implants. Thank you.